So AV blocks are up to three types: first degree, second degree, and third degree. In third degree there is complete block. You can see sinus node firing at one rate, AV node firing at another rate. First degree AV block is simply where there is prolonged PR interval of greater than 200 milliseconds. Second degree AV block is of three types. One is Mobitz type 1, which is also called as Venkivex. Then is Mobitz type 2. Then we get high degree AV block. This is high grade or high degree AV block. This also comes under second degree. Third is when there is complete block. No P waves, no atrial impulses are conducted to the ventricular side. What happens is Mobitz type 1, you get this is P wave and this is QRS complex. There is progressive widening of this PR interval, and finally one P wave is not conducted towards the ventricle. That's progressive, and then sudden drop, sudden block. Here we don't get progressive, this prolongation of PR interval. Here there is the PR interval remains unchanged prior to a P wave that fails to conduct to the ventricle. So there will be normal, but one P wave will not be conducted all of a sudden to the ventricle. That's Mobitz type 2 second degree AV block. Then comes high grade AV block, in which two or more consecutive P waves are not conducted. They will be like this: P wave, P wave. Minimum at least you require is minimum two P waves are not conducted. That is high grade AV block. Since there will be one P wave that will be conducted towards the ventricular side. In this case, this is called as high grade AV block, and it will be differentiated from complete AV block by the phenomenon that in complete, no P wave, not at all a single P wave will be conducted to the ventricle. But what happens? Sometimes it is difficult to differentiate between Mobitz type 1, or in other words, it's difficult to differentiate between Venkivex and Mobitz type 2 second degree AV block. The reason being, what happens sometimes in ECG, you get a 2:1 type of pattern where one P wave is conducted to the ventricle and another P wave is not conducted to the ventricle. That is 2:1. That's in every other P wave is not conducted. And in this, you don't get an opportunity to observe for possible PR prolongation. That is characteristic of Mobitz type 1 or Venkivex. So you don't get to differentiate, you don't get the opportunity to see whether this PR interval is getting prolonged or not, because this is a rhythm. This 2:1 AV block is in action. So you miss out the opportunity to determine which type of Mobitz block it is. Now, why is this condition a tricky condition? Because in Mobitz type 1 and Mobitz type 2 block, type 1, the clinical presentation is fairly benign, although it involves AV node, but it rarely progresses to complete heart block, unlike Mobitz type 2 block, which can progress to third degree or complete AV block. That's why thorough history, medication history, recent change in medication along with 12 lead ECG along with some blood work like electrolytes, TSH is necessary to determine whether this rhythm is Mobitz type 1 or type 2 in a case like 2:1 AV block. In some cases, what happens is patients who develop, for example, a patient with chest pain comes, ECG shows second, third AVF wall inversion, T wave inversion, for example, or ST depression. You diagnosed inferior wall MI, and if it is large size, it can involve this If it is large, it can involve this AV node and can lead to Mobitz type 1 AV block, second degree AV block, Mobitz type 1, and it has got a bad prognosis. So, large infarct of inferior wall can lead to ischemia of the AV node and lead to bradycardia. So, inferior wall MI patients can come to us with bradycardia. That means if inferior wall MI patients have bradycardia, that indicates poor prognosis and patient is likely going to die, because it means the infarct size is large. So bradycardia indirectly implies large infarct size. As already described, 2:1 AV block if present. Then how will you describe whether this is Venn-Quebec's or this is Mobitz type 2 second degree AV block? Answer is if the PR interval is greater than 300 milliseconds or the QRS complex is narrow, then the level of block is more likely to be in the AV node and the type is most likely to be Venn-Quebec's. So two things, PR interval greater than 300 or QRS complex. Also we see atropine response. If you give atropine 0.25 to 0.5 mg and rhythm changes to, or there is enhanced AV nodal conduction. For example, 2:1 goes to 3:1 block. That means enhancement of conduction. Now more PVOs are being conducted. That means this rhythm is most likely to be Mobitz or Venn-Quebec's type. That is the Mobitz type 1 second degree AV block or Venn-Quebec. Third criteria. This was second criteria. This is third criteria. For example, you give carotid sinus massage, and normally what do you expect? It causes this AV nodal conduction slowing. It causes carotid sinus massage. So you are likely going to see high grade block if it is a Mobitz type 1 or Venn-Quebec's block. That is, there will be conversion from Mobitz type 1 or Venn-Quebec's blocks will get converted into high grade block. That is, for example, this at 2 P waves or more than 2 P waves will not be consecutively conducted towards the ventricles, but after that P waves will be conducted to the ventricles. This phenomenon will only occur, that is Mobitz type 1 will get converted into high grade, but this is a risky procedure. But this maneuver, although risky, but will confirm that progressive increase in PR interval will convert the Mobitz type 1 or Venn-Quebec's into high grade AV block. But if it doesn't, it does the reverse. That is, conduction goes from 2:1 to 1:1. That improves. How does it improve? This apparent improvement in AV conduction with the slowing of the sinus node rate, for example, restoration of 1:1 conduction following carotid sinus massage, suggests that the conduction abnormality is below the level of the AV node. So if it is at the level of the AV node, then it is Mobitz type 1. If it is below the level of the AV node, then it is Mobitz type 2 second degree. So in nutshell, it is difficult to differentiate between Venn-Quebec's and Mobitz type 2 second degree AV block. You need atropine carotid sinus massage, or you need another thing, that is PR interval greater than 300 milliseconds or QRS narrow. Although this is a weak evidence, but atropine and carotid sinus massage you require a long rhythm strip to try to find out whether this is Mobitz type 1 or type 2. So, and do we need to treat Mobitz type 1 block? Yes, but only in two conditions: if patient is symptomatic or hemodynamically unstable, then you have to give atropine. You can give every 3 to 5 minutes 1 mg, total dose of 3 mg. But if that didn't improve, then you require this transcutaneous pacing. You can also use transvenous pacing. One of the symptom can be chest pain as well. So we mostly think chest pain is due to MI, but it can be due to block as well, like symptomatic block, and that in turn could be a result of inferior wall MI, which affect the AV node leading to Mobitz type 1 or type 2. Usually type 1 AV block is there, or when Quebec's block is with inferior wall MI, and that can lead to bradycardia. But that bradycardia has a negative prognosis, has a poor prognosis, because it will imply that the infarct size is large. Now, if there is inferior wall MI leading to Mobitz, for example type 1 block, then it should be treated with not atropine, it should be treated with temporary pacing and revascularization. And we expect that if the Mobitz type 1 second degree AV block that has occurred in the setting of acute MI, if it is treated with pacing and managed with this revascularization, the conduction abnormality is likely going to improve after revascularization. So AV nodal block as such is not dangerous, but infranodal block is dangerous because it can progress. It can progress and give rise to complete AV block. So that part has to be treated. If you identify a patient with infranodal block, for example Mobitz type 2 block, that's infranodal, you might go for permanent pacing because the chances of this tipping towards this complete AV block are higher. That's why permanent pacemaker is to be put in that patient. So, in nutshell, for the large majority of the patients with Mobitz type 1 second degree AV block and asymptomatic bradycardia, we suggest not implanting a permanent pacemaker. This is true in young patients and those patients in whom AV block is felt to be suprahesian. Suprahesian means above bundle of His, that's within AV node.